Hi, good morning to one and all. So, this is the part two of tooth preparation lecture. So, the name is Complete Cast Metal Crown, Metal Ceramic Crown, and All Ceramic Crown Preparation. Okay, so we are going to cover certain details about all three crowns and we'll talk in detail about the PFM crowns. Okay, so coming to the learning objective for the same. Okay, so first one is to summarize the recommended armamentarium for metal crown, PFM crown, and all ceramic crown. I discussed a disadvantage, advantage, indication, contraindication for each of the following. Recall step-by-step procedure, the preparation detail, the anterior and the posterior preparations. Okay. Okay, coming to the armamentarium, that is the material which is required for a full metal crown preparation. So you need a handpiece, you need a 7171 L burr, round and tapered burr. So you can see the photos which are here. Short needle diamond burr, torpedo burr, and red utility wax. Okay, and you can see the photos. All right, coming to the metal ceramic crown preparation, same few will always remain the same, you know. Okay, so handpiece, the 171L burr, round and tapered diamond, flat and tapered diamond, short needle diamond, torpedo burr, red utility wax. Okay, for all ceramic you need a handpiece, 171L burr, round and tapered diamond, flat and tapered diamond, short needle burr, and red utility wax. Okay, so just know those armamentarium and you use it daily so you understand that we are using those burrs and handpiece and everything every day. Okay, coming to the advantages of all the three of the following. So, full metal, yes, gives great retention and resistance form. It has high strength. It has a good protection to the teeth because it gives a coverage. It is long lasting, removal of less tooth structure because you do the least amount of preparation in the full metal preparation. Coming to the PFM crown, in this preparation, you have other various advantages, which is it has high strength and it has good aesthetics as well because this is a metal reinforced with a porcelain layer on the top. It is less expensive than an all ceramic crown. It has good retention. We are doing it daily, guys. Here, students are doing it daily. It permits easy correction of the axial wall. So yes, you can correct all the walls and the preparation can be even throughout and it can be done well. Okay. Um, for all ceramic, you have excellent aesthetics. So aesthetics is it cannot be compared with any other crown. There are many types of all ceramic crowns which are done. It has good tissue response even for subgingival restorations. It is more conservative for facial walls rather than a PFM preparation. All right. Coming to disadvantages for full metal, yes, it has very poor aesthetics because, yes, there's metal. Yes, there are chances of metal allergy, difficulty to do test vitality of the tooth, especially by electric pulp testing. In PFM, not perfect aesthetics, but it's acceptable, guys. Sometimes metallic margins are visible. Translucency is much lesser than an all ceramic. And it's may discolor porcelain. So yes, there are some discoloration sometimes in the porcelain layer, and porcelain might fracture. This is common finding in the PFM crown, which is seen, which sometimes bring the patients here to us. All ceramic, there it has a reduced strength, yeah, sorry, compared to PFM, yes, actually it is. It's more fragile. Requires skills for preparation. Okay, it's extremely critical and it has to be done properly. Otherwise, you're going to damage more structure of tooth than you're supposed to prepare. Okay, least conservative preparation, brittle in nature of restoration. Okay. Coming to the indications, so these are just some general main indications. There are many more. I've just written 4 to 5 indications, so you can read more in detail from the books. Okay, so for metal crown, indications are a tooth with extensive destruction due to caries or trauma in order just to protect the fractured tooth segment. It can be done. So a tooth with large amalgam restoration in order to protect the remaining tooth structure and amalgam from fracture. Okay. Endodontically treated teeth, so RC treated teeth. you can ideally do any of the crown of the following. But yes, one of the indications is this: when maximum retention resistance is needed, as in tooth with short crowns is indicated. Recontouring of tooth, as in tooth receiving a class for removal partial, and if required it can be done. Okay, contraindication: if high aesthetic is in need sorry, if high aesthetic need is demanded, then obviously it's not indicated. When less than maximum retention and resistance is necessary. When a more conservative crown, the 3/4 crown, right, can be done, like the veneers and things can be done, yes, this is contraindicated when the caries index is okay. Coming to the indication and contraindication for the PFM crown, guys. Okay, so indications usually is teeth that require complete coverage. Okay, aesthetics is one of the main concerns, especially anterior teeth and patients' concern. Okay, extensive tooth destruction, which results in caries or trauma, endodontically treated tooth, need for recontouring of any of the walls, or minor mal inclinations also can be corrected if all ceramic crown is contraindicated. Okay, so contraindication is active caries. Obviously you cannot give untreated periodontal disease. So periodontal status has to be stable for any of the FPD indicated cases, otherwise FPD is not indicated. Young patients with large chambers, high risk of pout exposure, objectives met with more conservative preparation, okay, like composite resin or porcelain laminate veneers again. So if conservative preparation can be done, then we should not be doing crowns, okay, and then the crowns automatically become contraindicated. Okay, so for indications, sorry, this is for all ceramic crowns. So indication: high aesthetic requirements, a considerable proximal caries. So this works very well for the coverage and giving the strength to restoring one surface of the tooth which is gone from proximal caries. Incisal edge reasonably intact, and yes, this will give you more translucency. It has more shades. It looks more aesthetic. So yes, endodontically treated teeth with post and cores, favorable distribution of occlusal load, and also specially indicated in the anterior teeth. Yes, anteriorly it's a more aesthetic zone, so the patient do prefer this. Contraindication: when superior strength is warranted and a metal ceramic is more appropriate. So yes, there are places where you can just do a PFM and you don't need to go through the long route, guys. So it can be done. Extensive caries, insufficient coronal tooth structure for support. So no, it will break off, it'll fracture off, and not required. Thin teeth facial-lingually contraindicated, guys, because you have to do a little bit more amount of preparation compared to the other preparations. Unfavorable distribution of occlusal or bruxism. All right, so you just know those things. Okay, so now we are just going to focus on the PFM. Yes, we have done it, guys. And we are just going to focus on PFM, that is a porcelain fused metal crown. Also known as a metal ceramic crown, consists of a ceramic layer bonded to a thin cast metal coping that fits over the tooth preparation. Okay, so it combines the strength and accurate fit of cast metal crown with the cosmetic effect of a ceramic crown. So basically you can say it's giving the strength of both, and yeah, so it's basically covering both the crowns together, right, and it has greater longevity. Okay, coming to the anterior porcelain fused metal crown. Okay, so PFM anterior, guys. So almost the same armamentarium, lab knife with 25 number blade. So this is for the silicon putty accelerator. This is for the putty index, which you take after. I am not covering the putty index in this lecture. You can definitely read it in the book. Handpiece is required: flat and tapered diamond burr, small wheel diamond burr, long needle diamond burr, torpedo burr, radial fissure burr, and biangle chisel if required, guys. We actually don't use it. Okay, so coming to the steps. So these are the basic steps. I'll be covering the each steps in detail, and I'll be showing you photos for the same. So first is to make a depth orientation grooves. Okay, Yeah, this is done. Then incisal reduction is taking place. Then you take care of the labial reduction, which is done in two planes. Lingual reduction also done in two planes and then merged. Uh, then in initial proximal reduction, lingual axial reduction, axial finishing, axial and shoulder finishing. Okay, so step one is placement of deep orientation grooves on labial and incisal surfaces. So you can see incisal and these are the labial surfaces. Yes, so we are using a flat and tapered diamond burr. Okay, using a flat and tapered diamond burr, they are means of judging the amount of tooth structure to be removed. So you should embed the burr and you can measure the depth. Okay, full diameter of the instrument of known dimension is sunk into the teeth. Okay, so the depth of the reduction can be checked with the uncut surface of the tooth. Okay, so this can be marked and you can orient it in two ways because there is a facial plane and incisal plane. Okay, so there is a and you can do it in two planes. Okay, labial groove should be cut into two sets parallel to the gingival half of the labial surface and then to the incisal half. Okay, so these are the two planes. The depth should be 1.2 deep. Okay, incisal groove should be cut all the way through the incisor and should be 2 gingivally. Okay, all right, to achieve adequate reduction without encroaching the pulp, facial surface is prepared into two planes. So guys, again, two planes, yeah. Reducing the facial surface and extension of gingival plane can cause the incisal edge to protrude, resulting in bad shade match and or contoured block. So reducing the facial surface and extension to of incisal plane can cause the surface to be too tapered and close to the pulp. So if you either reduce the gingival or the incisal plane too much, it's going to cause problem in exposure of the pulp. So and over contouring or reduction. So you should have a sub reduction and do it into two planes, guys. Okay, so it is important to reduce the label surface in two planes for the PFM. Okay, so if only one plane is required, it can be done. This is over contoured, guys. Okay, and here it's kind of encroaching the pulp now. Okay, this is too straight. Okay, so you are supposed to have two planes reduction. Okay, coming to step two, which is the incisal reduction. So using a flat and tapered diamond burr here. Okay, and then you can just reduce it. Done first to allow easy instrument access to the axial surface and gingival finishing lines. Inadequate reduction will cause poor incisal translucency in finish restorations. Okay, so we need to have some clearance, guys. Yes, so basically incisal reduction to get incisal clearance. Okay. Okay, step three is the labial reduction. Okay, so incisal portion, you can see that with using again a flat and tapered diamond burr, all tooth surface planed off to the depth of the orientation grooves. Okay, so you're supposed to just plane it off and make it into one plane. Okay, so the gingival portion, as you can see, using flat and tapered diamond burr tooth structure plane off to the depth of orientation groove. So it's reduced around labioproximal line angles to the zero point 0.1 mm lingual to the proximal contacts. Okay, so from here to here, basically. Okay, so that's how you do it. Coming to the lingual reduction, guys. So in the lingual reduction, what you do is using a small wheel diamond burr, a minimum zero point 0.7 clearance with the opposing teeth has to be there. So this is the clearance we are talking about, okay? When we occlude. Those portion of the lingual surface which will bear the ceramic veneer should be, or ceramic, the ceramic portion there, sorry, okay, should be 1 mm clearance, okay, should have, guys, okay? So junction between the cingulum and the lingual wall should not be over reduced, okay? So junction between the cingulum and the lingual wall should not be over reduced. Okay, it may affect the retention, guys. Okay, all right. Coming to the initial proximal preparation. Okay, so the mesiodistal. So long needle diamond burr is used. So what we do is we cut through and through distally and mesially in the long axis just near the edges, and we nick off the enamel lip or the remnant of the enamel from the probe or from the instrument. Okay, all right. So by that, you reduce the chances of nicking the or injuring the adjacent teeth proximal area. Coming to lingual axial reduction, so using a torpedo diamond burr, reduce the lingual axial and also some portion of the lingual surface. Okay, so lingual axial reduction is done. Okay, yes, lingual and axial reduction. Now coming to the lingual and axial finishing, so it can be done by a torpedo burr, okay, done to accentuate the chamfer finishing line on the lingual and proximal axial surfaces, okay, so you can see the margin form, okay, axial and shoulder finishing line. So using a radial fissure burr, um, the to smoothen the labial surface and form a radial shoulder finishing line, all angle and edges of the preparation are rounded, okay, so to facilitate the seeding of the restoration. Okay guys, so usually you can just give a shoulder all around margin and yeah, and then you can do a finishing, the finishing burr, the yellow band burrs. Okay, the cutting burrs are the red band, the blue band, and the green band burrs. Okay, finishing has to be done. And yes, guys, the amount of taper has to be given in these restoration. Okay, so you can give 6 degrees taper, and the preparation cannot be really parallel. Okay, right. For the posterior PFM. Okay, now, so coming to the armament, they are almost the same, guys. Lab knife with 25 number blade, silicon putty accelerator, handpiece, flat and tapered diamond burr, shot needle, diamond burr, torpedo burr, 158012 radial fissure burr, RS1 biangle chisel. Okay, we are not using. Okay, steps, they're almost the same, but of course, in relation to the surface in the proximal, sorry, in the posterior teeth. Okay, so coming to the first one, that is a planar occlusal reduction, functional cusp bevel, facial reduction, proximal axial reduction, lingual axial reduction, and finishing facial, axial, and shoulder finishing. Okay, coming to step one, that is occlusal reduction, guys. So you can see there are a lot of planes, grooves, and fissures which has to be followed. Occlusal preparation for any posterior teeth, maxillary mandible cannot be flat, guys. They have to follow the grooves and the cusp and the fissures which are present. Okay, so 1.5 mm of clearance on functional cusp and 1 mm on the non-functional cusp. Okay, so for the maxillary, the functional cusp would be, guys, which one? Yes, so it would be the palatal for the upper, for the maxillary, and for the mandibular it would be the buccal cusp. Okay, which is the functional cusp. Okay, so yes, slight differences there. Depth orientation grooves are placed on the occlusion surface with the round and tapered diamond. Okay, so you put the depth orientation groove and then you merge it. Okay, yeah. Okay, so round and tapered. Yeah, sorry. Round and tapered diamond is used to place the grooves on the ridge and primary grooves on the occlusal surface. Okay, if there is already some clearance with the opposing tooth, because of the malposition groove should not be made as deep. Okay, so yeah, okay, so that can be judged clinically, depends case to case. So guys, that's how you place a groove and then you merge the grooves. Okay, and then you get the clearance. Okay, the occlusal reduction should follow the configuration of the geometric inclines that make the occlusal surface of any posterior teeth. Okay, so you should just follow all the inclines. Okay, there should be no different anatomy, guys. Okay, yeah. Okay, so step two is the functional cusp reduction. So functional cusp bevel with round and tapered diamond has to be done. The wide bevel is placed on the functional cusp orientation groove, will also help in the reduction. Okay, so you can see that now they're starting with the functional cusp reduction. Okay, okay, and of course there's a bevel which is given, guys. Okay, functional bevel is integral part of the occlusal reduction. Okay, failure to place the bevel would produce thin casting and poor morphology. It has to be given, there is an importance. Okay, occlusal clearance is very important, guys. It can be checked by wax, so you can tell the patient to bite on the wax, and if you see that there are holes, that means the clearance is not adequate. And if there is no holes and it's not perforating the wax, that means it is fine. So red utility wax is used. Okay. Step 3 is facial reduction, guys. So buccal and lingual walls are reduced with the round and tapered diamond. The sides of a diamond will produce the desired axial reduction, while the tips will form the chamfer. Okay, so the tip also has a cutting edge and the surface also has a cutting edge. Okay, so whichever finishing line you're looking for, you can make it properly and use the desired burr. And the buccal and lingual wall reduction has to be taken place, okay, in the inclines of the teeth, guys. So you're not going to create a new anatomy. Okay, so there you can see, guys. Okay, a better view. Okay, coming to the proximal reduction. Okay, so that's step 4, initial proximal axial reduction with short needle diamond followed by a round and tapered. Okay, so these are the two burrs you're following. You can see that the proximal reduction is going the same. You can follow the same principle. Nick off from here, make a cut and nick off from the instrument so you do not injure the adjacent teeth. Okay. Okay, sorry. Step 6 is the facial axial reduction. So again, a seating groove can be given like that from 171 L burr. So that's the number of the burr. And then you can reduce it. If you don't want to, you can just reduce it in a hole, guys. Okay, in surface. Okay, so this is preparation of a bridge, so you can appreciate, guys, the occlusal view, the bird eye view, the lateral view, and a closer view. Okay, yeah. So guys, one last thing, as I want to summarize in one line. I have told this to every student who does the preparation, guys. So the tooth preparation is the miniature version of the actual tooth. So we need to preserve the all the anatomy, the grooves, cusp, fossas, cingulum, everything as it is. There cannot be any sharp line angle, point angles. Everything has to look merged and smoothened. And occlusion cannot be flat, guys. Okay, and it has to follow the proper anatomy. Okay, but in a reduced version. So you cannot create a new anatomy or you cannot flat out the anatomy. Okay, so guys, for reference textbooks, you read textbooks on FPD, which is Schillenberg and Rosenstiel. Okay, so those are the standard textbooks for FPD, fixed partial dentures. Refer to them, guys, for any further questions. We are here on floor 20 in our Prosto Lab, Polyclinic 3. Come and ask us questions, okay? And read, guys. Okay, thank you so much for patient listening.